Thank you very much, Dr. Ahmed, for this introduction, and thank you all here, the audience. And great thanks to Sanofi, who invited me to speak in this wonderful gathering. The slides, next from here. Thank you. Those are my disclosures. And why allergic rhinitis? Actually, allergic rhinitis is always and will continue to be a very hot topic, despite the fact that we see so many patients every day with allergic rhinitis. Is still a hot topic. Why is that? It's because it's very common. It's one of the commonest chronic diseases we encounter in medical field, and it is the commonest type of rhinitis. It's not fatal, but it might actually significantly impact the quality of life of those patients who are affected by affecting their school performance, their work performance, their sleep, and their general life. It's also very prevalent. Worldwide, the incidence is about 10 to 30%. It goes up to 40% among pediatrics. I'd like to share with you some of these statistics from Saudi Arabia and the largest scale survey, which shows that about 34% of adults and 26% of pediatrics in Saudi Arabia, they are suffering from allergic rhinitis. The most common allergen is dust mites, and most of those patients, the majority, I would say 2/3, they actually reported moderate to severe symptoms. Why it's very prevalent, and why it's actually the prevalence is increasing with time. There are three theories to explain this. The first theory is the hygiene theory. The more we are hygienic, the more when we expose to any allergens, we become very sensitive to those allergens. The lifestyle that we are living nowadays, the sedentary lifestyle, the more exposure to the indoor allergens, the molds and the house dust mites leads to more allergy. Pollution, as my colleague just mentioned, now, pollution is one, because we have more factories, more industries, and more pollution, and sometimes some of those countries, they're not very aware about the pollution. This leads to more, actually, allergies. Nutritional theory is very important, because I have one study about this, where actually it was found that some nutritional deficiencies, like vitamin D in particular, it is actually associated with the severity of allergic rhinitis, and in pediatrics, it's associated with the development of bronchial asthma. So how symptoms develop? All of you know the pathophysiology of allergic rhinitis, the first exposure where our B cell will form the specific IgE for those allergens. The second exposure is where we develop the symptoms, actually because there is already IgE in our body, and the allergen will bind to the IgE on the surface of the mast cell, leading to degranulation of the mast cell and release of the inflammatory mediators that will lead to cascade of inflammation. And a second phase, because of the attraction of the inflammatory cells to the site of inflammation, nasal mucosa will lead to the second or late phase. And those symptoms will include the itching, sneezing, because of the irritation of the nerve endings, will lead to excess rhinorrhea because of the hyperplasia of the goblet cells, and the increase in the mucus production will lead to congestion, edema, and feeling of nasal blockage because of the vasodilatation and the increase in the vascular permeability. And this will all be because of the exposure to the allergens and pollution as well. So allergens, the most common allergens, as you all know, is the dust mites, pollens, molds, and animal products. Those contribute for about 97% of the allergens that causes the allergic rhinitis symptoms. Only 3 to 5% may be caused by food exposure to some kinds of foods, and in particular in pediatrics. Symptoms, as I mentioned, they are the most common is the nasal symptoms, but it can go beyond nasal symptoms to eye symptoms, to actually headache, drowsiness, ear symptoms, cough, throat itching, and mouth breathing as well. And the patients who are having allergic rhinitis, you can spot them sometimes when they come to your clinic. You can see that they have this double crease under eye, darkness under their eyes. When you examine them, the turbinates are very swollen, pale bluish color. And pediatrics, they have usually what we call the salute sign, or the transverse crease above the tip of the nose because of the excessive itching and wiping of their nose. Complications, they can actually present sometimes with the complications, and retrograde, you will discover that they have allergic rhinitis, and this includes some otitis media or Eustachian tube dysfunction, sinusitis, overbite, and sleep disturbances, and sometimes they actually present to their pulmonologist with a very poor control of their bronchial asthma, lower airway. The symptoms of allergic rhinitis is very common among a lot of rhinologic diseases, and that's why the differential diagnosis is very wide. And actually, any disease that can cause similar symptom is considered to be one of the differential diagnoses, including masses within the nose that causes blockage. If you see them at the primary healthcare setting, you might mistake those and give them intranasal corticosteroids, thinking that they have just a blockage because of allergy. So symptoms alone cannot confirm allergic rhinitis. It has to be associated with exposure to the allergens. There is no single diagnostic test to diagnose the non-allergic rhinitis. And as you can see in this very, very busy table, a lot of differential diagnosis could be drug-induced, hormonal, autonomic, like the vasomotor rhinitis, food-induced, atrophic, etc., etc. Even systemic disease, like some of the autoimmune diseases, can have some rhinitis presentation that might mimic allergic rhinitis. Those are just some of the differential diagnoses that if you suspect, if at the level of the PHC or you are a family physician and you suspect allergic rhinitis and you give a treatment and the patient did not improve even after stepping up, just consider the non-allergic type. The other differential diagnosis, maybe you need to refer to an ENT specialist to take a look inside the nose and come up with do further investigation to actually diagnose the patient. So very simplified way or algorithm to diagnose patients. We used to say that allergic rhinitis is a clinical disease because it's based on taking a very good history of symptoms of allergic rhinitis in exposure to the allergens, not symptoms without exposure to allergens. And of course, the detailed history of comorbidities, drug history, and et cetera, et cetera. Then after taking a good history, do a very good examination and look at the signs of allergic rhinitis. If so, you can initiate the therapy with one of the pharmacotherapy plus avoidance measures if possible. Follow up the patient. If there is no improvement, you can step up. If there is improvement, you can step down. But if everything is done and there is no improvement or not control the symptom, think of doing allergy testing. And if the allergy test is positive, it's confirmed, you can actually escalate your treatment or actually offer immunotherapy. If not, you have to refer to an ENT specialist or do further investigation if you are already an ENT specialist. This is just simplified way of management of allergic rhinitis before going into the protocols. Now, the types of allergic rhinitis, as you all know, they are divided according to seasonality into intermittent, persistent, according to severity into mild, moderate to severe. Mild when there is no other symptoms except the not bothersome, the symptoms, and severe, moderate to severe when they're bothersome, affecting the lifestyle, the sleep, or the work, or the school performance. This is what we are going to go through, the protocols for the management of allergic rhinitis, all of those protocols. So we'll start with the USA or US Allergic Rhinitis Guidelines, where they're actually talking about the pharmacotherapy for allergic rhinitis, and they divided it into three types: the intranasal corticosteroids, the oral antihistamine, the intranasal antihistamine. So when we look at the intranasal corticosteroids, we can see we have a variety of them. All of of them, they can be used for both perennial and seasonal allergic rhinitis, and they are actually safe, can be given to pediatric age groups starting from 2 years of age, according to the FDA authority of your country. Because as you see in this now, so intranasal corticosteroids indicated for all types of allergic rhinitis and can be given for even above 2 years of age pediatrics. The oral antihistamine, you can see we have also a variety of second generation oral antihistamine, which is the recommended one for the use and treatment of allergic rhinitis. Cetirizine and disloratadine can be given to children at the age of 6 months and above, which is very good. And you can see that fixofenadine here in this slide and this guidelines, at that time, there was no control studies to show, no RCTs to show that fixofenadine is actually effective for perennial allergic rhinitis, so it was the only one for only seasonal and maybe for pollution-induced allergic rhinitis. So in general, oral antihistamines are indicated for all types of allergic rhinitis, if they are more than 6 months of age. What about the intranasal antihistamines? Intranasal antihistamines, the one available now is the olapatadine and azilastine, the most common. I would say they are available as intranasal solo or in combination with intranasal corticosteroids. And they are effective, and actually they can be prescribed for children above the age of 6 years old, and again, according to your local FDA guidelines or approvals, because in Saudi Arabia, they are only approved for above 12 years of age. So they're indicated mostly for seasonal allergic rhinitis and for any patient who's above 6 years of age. So when we look at all of the three, we can see that intranasal corticosteroids are actually very effective for all the symptoms of allergic rhinitis, and they are significantly effective for both seasonal and perennial rhinitis. Whereas the oral corticosteroids are mostly effective for the runny nose, sneezing, and itching, and they are mostly for intermittent rhinitis. Intranasal antihistamines is actually given a moderate effect on all of the symptoms of allergic rhinitis and for only seasonal and intermittent type of allergic rhinitis. And the statements of recommendations from the American Academy of Otolaryngology guidelines is that topical steroids is strongly recommended for treatment of allergic rhinitis. Oral antihistamines is strongly recommended, especially for patients with primary complaints are sneezing and itching. Intranasal antihistamine is optional and can be given as an option for the patients with allergic rhinitis. Of course, combination therapy or immunotherapy and turbinate surgery, they are all reserved in those guidelines to step up for patients with allergic rhinitis. So if they are not improving with one therapy, you can give them combined therapy, or you can offer immunotherapy or inferior turbinate reduction according to the condition of the patient. So the medication step up, according to the guidelines, is that when the patient, the intranasal, it shows here that when you use the intranasal, it works. Intranasal steroids as a monotherapy, you can step it up to intranasal, to add intranasal antihistamine with it. So you have to give the combined therapy as a step up, or you give a short course of decongestant. However, when you have the intranasal antihistamine as the primary therapy, you can step it up to intranasal corticosteroid alone or intranasal corticosteroid with intranasal antihistamine. However, when you start with an oral antihistamine, you cannot do a step up by adding another medication because it doesn't work. Because actually this is not recommended, and it has no value. You have to shift the patient from oral antihistamine to intranasal corticosteroid or intranasal corticosteroid with intranasal antihistamine. And they put different scenarios to show how you can step up your medication. I'll not go through it because it's the same what we mentioned before. Now, after it came the area guidelines. Now, both the American group and the European group, they are looking at the same data and the same publications, the same RCTs published. And they are discussing it and coming up with guidelines. So supposed to be the guidelines are the same, except with minimal changes. If they're looking at the same data, they should extract the same guidelines. And exactly this is what happened, except for a few minor variations. I will highlight the variations and the guidelines. The area from the American Academy first is that the area, they think that in seasonal allergic rhinitis, you can actually combine the intranasal corticosteroid with oral antihistamine, or you can give intranasal corticosteroid alone. And they think that they are equivalent. You have the choice to give both or alone. Unlike the American, who thinks that adding oral antihistamine to the intranasal corticosteroid will add no value. The second one is that both in seasonal and in perennial allergic rhinitis, when it is severe or symptoms moderate to severe, you have the option to give the patient intranasal corticosteroid alone or intranasal corticosteroid with intranasal antihistamine. So those two are equivalent, and the choice is based on the patient's history, a lot of factors, the preference, and so on. Now, in cases of mild disease, either seasonal or perennial allergic rhinitis, it's either you can start with either antihistamine or oral antihistamine. So those are the major differences between the two. But then that guidelines was published, and just 3 years later, they published the next generation guidelines, which is the grade guidelines. So what's the difference? And usually, the guidelines usually are published every 5 years. So why the area, they start to publish before the 5 years? Because they found that actually the evidence based on RCTs alone does not reflect the actual let's say, effect of the medication and the actual suffering of those patients. So for certain reasons, like guidelines are not sufficiently followed by all clinicians, and they are not close enough to the patient's need and probably do not reflect the real life. So they came up with the next generation, the grade-based guidelines, which utilizes not only the RCTs, but also the real-world data and also some experimental studies or experimental findings from putting the patients in the chambers where they expose them to the allergens, see their development of symptoms, severity of symptoms, give them the anti-allergic medication, and see how they would respond to those medications and the duration or the onset of action of those medications, the efficacy of those medications. Based on the three, they came up with the grade guidelines. So it's the grade guidelines. Also, they found also that pharmacotherapy, the aim is that to control the disease. And the control of the disease is not only dependent on whether it's seasonal or perennial, and not only dependent on the severity. To control the disease, you need to think about the patient preference, the age of the patient, the most prominent symptom of the patient, symptom severity, comorbidities, efficacy and safety of the treatment, the current treatment, the history of previous treatments, and the onset of action, self-management strategies, and the resources used. So they use the RCTs, they use the real-world data by coming up with an app. I don't know if you heard about this app or if you download it. This is an app that created by the area group, and app is for free. You can download it from your Android or your smartphone. And this application allows you to record all your journey with allergic rhinitis, symptoms, signs, whatever, response to treatment, type of treatment on daily basis. It's available in 23 countries in 17 languages, and it was utilized till the year 2019 by more than 30,000 people. So out of this mask application, they found that patients, even if those patients are actually physicians, they are very poorly adherent to the treatment. They don't follow any guidelines. They use the medications when they need, and they are self-medicated. And they found that there is a very poor control with oral antihistamines alone. Combination of intranasal antihistamine and intranasal corticosteroids is more effective than intranasal corticosteroids alone, and more medications does not yield a better control. And from the chamber studies, they actually looked at the efficacy of the medications and the onset of action. And they found that only intranasal corticosteroids with intranasal antihistamine are the fastest, they have the fastest onset of action, and they can actually relieve the symptoms within 5 minutes. Others, they take longer time than this. And this is the results of the chamber studies. They actually classify the treatment for allergic rhinitis, the pharmacotherapy, into T1 to T5. T1 is the antihistamines, T2 is the intranasal corticosteroids, T3 is the nasal and nasal corticosteroids and antihistamine, and T4 is the oral corticosteroids, and T5 is the immunotherapy. They make it easy so that when they put the protocols, they can tell you shift from T1 to T2, step up to T2 or T3, and go down to T1, and so on. So this is to make it easy. And by this, they actually came to consensus about so many different scenarios. It's actually 34 scenarios. So if you look at these scenarios, do you think that we will apply those guidelines? How can we memorize the 34 different scenarios and know when to use T5 or T2 or T3 or whatever? For me, I wouldn't use them, actually. But I'll tell you, we will simplify it for you. It's very difficult to follow this. And even if you print it and put it in your office next to your desk or clinic, you will not be able to focus which the patient belongs to which scenario. So in general, or just to summarize, if you have intermittent or persistent with symptoms, objective symptoms. Objective means you can measure, they allow the patient to measure their symptoms according to the VAS. So not only moderate to severe or mild, depending on whether it affects your sleep or something, it is now more objective measurement of the system using intermittent or persistent. Also start with monotherapy, but it depends. When it is intermittent, moderate to severe, you can start with monotherapy, and if the patient does not improve, you can step up after 3 days. However, if it's persistent and moderate to severe symptoms, it's better to start with either intranasal, with either T2 or T3. So T2 is intranasal corticosteroids, T3 is combined intranasal corticosteroids with the intranasal antihistamine.
Dr. Nada, we have 2 minutes.
2 minutes plus. Okay. So those are the algorithms that they come up with. I'll try. So simply, they divide the patients 2 algorithms only. They divide the patients into 2 groups. One algorithm is for the patients who never received the treatment before. So they call them the naive patients, never had any treatment. You start with monotherapy, and then you measure the response after 3 days. If it's still the same score, then, and the persistent symptoms, you can actually step up. If the symptoms actually maintained, become better, you can continue the treatment, or you can consider discontinuation of the treatment. However, if it is, the score is more than 5, moderate to severe, and it is intermittent, then you can start with any treatment, any one of the monotherapy. However, if it's persistent, as I mentioned, and severe, you have only the 2 choices, either the intranasal steroid or intranasal steroid with intranasal antihistamine. Step up, step down is depending on the response of the patient. And you think about step up according to the T level, T1 to T5. You can see here, and the previous slide as well, that actually considering immunotherapy can be within just the 2nd visit of the patient. Do we really consider immunotherapy from the 2nd visit? We don't in our countries, but here, according to the guidelines, within 10 days, you can offer the patient, if not improving or not controlling his symptom, you can offer him immunotherapy. So patient preference here is very highly considered. And the next algorithm is for patients who are actually symptomatic patients. They have a treatment already, but you need to adjust the treatment. Again, it's the same guidelines. Later, the Americans Just 1 year later, they put the other guidelines. Again, they looked at the same studies and the same RCTs. They use also a real-world data and experimental data, and their guidelines is no different than the area guidelines. The slide is even very, very busy. And they said we come up with very sophisticated algorithms. We could not simplify it further because we have to put into consideration the different aspects of the patients with comorbidities, with symptoms, severity, and so on. So they could not simplify it. They make it more even complicated for just allergic rhinitis. So just studying those two algorithms, just to come up with the conclusion, they are the same, exactly the same guidelines as the area. And I just would like to highlight the fact that when you're a patient having moderate to severe symptoms, persistent, like here in our countries, most of the symptoms are persistent. In Saudi Arabia, as I mentioned, 2/3 having persistent and moderate to severe, consider starting intranasal steroid or intranasal steroid with intranasal, the combined therapy with intranasal antihistamine. They also give consideration for the subpopulation with allergic rhinitis, like the pediatrics. I will not talk about it. You can see not all also are safe. And if you will prescribe antihistamine, think of cetirizine, 1 minute more please, cetirizine or loratadine, and think about budesonide, fluticasone, mometazone. All are safe, but starting from the second trimester. Elderlies, think about the most common symptom is rhinorrhea. So try to give them something for their rhinorrhea. When you give antihistamine, give the second generation always. The last but not the least is the one slide about the guidelines, which is published just recently about the immunotherapy for inhalant allergy. So it's not for only allergic rhinitis, but for allergic rhinitis and asthma. And basically, those are the statement, this last slide, statement of recommendation. So immunotherapy is indicated for allergic rhinitis where their symptoms are in, or those who have preference for immunotherapy. So now patient preference is very important. Even if their symptoms are controlled with pharmacotherapy, but they prefer to have the immunotherapy, you should offer them the immunotherapy. Should not be given to patients with uncontrolled bronchial asthma or those patients who are unable to tolerate the injection of epinephrine, or pregnant ladies. You should not initiate immunotherapy in a pregnancy, but you can continue if they're started, and you have to reconsider in patients who are on beta blockers or who have systemic immunocompromised status. So to take home message, this is my take-home message. Can I say it or? Okay, thank you. Take-home message is, of course, history, physical examination. Again, we are going back to the basics. History, physical examination, even allergy testing are very important to give you a clear picture of allergic rhinitis and confirm the diagnosis. The treatment strategies are not only based on seasonality or severity. Remember the patient's age, remember the phenotype, the predominant symptom, the existing treatment, and the improvement with any previous treatment, and of course, patient preference. For mild, the primary treatment is either one of the available medications, monotherapy. For moderate to severe, with moderate to severe, if it's intermittent, start with any monotherapy. If it's persistent, give them either intranasal corticosteroid or intranasal corticosteroid with intranasal antihistamine. A step up of the visual analog scale or symptoms is still more than 5 or less than 5, but no improvement to T3, T4, or T5, and a step down if the symptom score become less than 5. Combination of oral antihistamines and intranasal corticosteroids, according to the latest guidelines, it doesn't work. This is the very common, maybe very commonly prescribed to the patient. Both these, this one does not help the patient and does not have any additive effect on the patient. Thank you very much, and I'm so sorry to take this long of your time. Thank you very much.